Honorable Chairperson, respected discussion and learned audience. I am Dr. Iqbal Mahmud, working as Fellow Interventional Cardiology, Fortis Scott Heart Institute, New Delhi. I am presenting my case, Tit for Tat, Diamonds for Rock. So 60 years gentleman, presented with chest pain and choking sensation on exertion for 2 months. Worsening since last 2 weeks. Patient is known case of ischemic heart disease and his status post PTCA to RCA in 2007 and RCA and LCX in 2017. Patient was diabetic on oral antibiotic drug, normotensive non-smoker. On presentation, his ECG was normal, heart rate was 68 beats per minute. On echo, there was regional wall motion abnormalities in LAD territories and EF was 45%, his hemoglobin was 12.2 and serum creatinine was 9 and calculated creatinine clearance was 88. This is angiography. On angiography we see the lead vein is short and there is a LAD ostial has got 90 to 95% lesion and proximal to mid LAD there was 80 to 90% severely calcified lesion as this calcification is visible in either waters of this fluoroscopy. And LCX there is a patterned stent and OM1 ostial has got borderline lesions. In RCA, in mid RCA there is 80 to 90% ISR and distal RCA has got 90% ISR just distal to this stent. So how would we treat? First we plan to fix his RCA lesion. Then we have achieved some reserve during left-sided lesion. And for left-sided, we decided to first do intravascular imaging. As it is severely calcified, we plan for some debulking therapies followed by stenting. So we treat distal RCA by 3.5 12 days at 16 atmosphere and mid RCA in 4 into 18 days. And in right panel, there is a final results of RCA, and this is the IVAS comparison of pre-stented. The minimal luminal area was 3.5, which was minimal stented area was 9.9 after stenting. So we proceed for treating LAD lesion by newer calcification modification device, that is orbital atherectomy. This was the angiogram. So for left system, we engaged LMCA by XB3 7 French guide and we negotiated transfer wire to LAD, and we tried to do IVAS, but unfortunately we could not cross this lesion by IVAS catheter, so we went for upfront orbital atherectomy system. These are the available calcium modification device in our center, as this lesion was untraceable by IVAS catheter, so we plan to atherectomy. And this is the newer calcium modification device, orbital atherectomy system, which consists of OS pump, which is totally electrically driven and quite different from rotational atherectomy, all of you know, which is driven by gas pressure. And another thing is this, in orbital atherectomy system, there is an eccentrically mounted 1.25 millimeter bar. This is the single size bar by which we can use 2.5 to 4 point vessel, any size of vessel from 2.5 to 4 millimeter by this single size wire. And there is a special wire, this is Viper wire. It is nitinol core 1 gram tip load. It's like any Rancho wire and it is softer than this stainless steel wire of rotational atherectomy. And actually orbital atherectomy acts through is centrifugal force. By this centrifugal force, it caused bidirectional differential sending of superficial calcium, as well as by pulsatile force it can modify the deeper calcium. If we see to the mechanism of actions of different calcium modification devices, in rotational atherectomy it acts through the differential sending, and IVL which acts through pulsatile force. But this orbital atherectomy which acts by both ways, by differential sending, it's sending out the superficial calcium, and by pulsatile force, it's crack deeper calcium. So, and another unique features of orbital atherectomy is we can pull back and we can do retrograde barring by this orbital atherectomy system. So for ostial LAD, we decide to retrograde barring. We first negotiated this orbital atherectomy system beyond this lesion, then we pull it back for ostial lesion, and for proximal to mid, we went anti-capation. And in orbital atherectomy system, there is two fixed rotation. It is fixed. Low speed is 80k RPM and high speed is 120k RPM. But in rotational atherectomy, this speed can be determined by the operators. So we used 18k RPM, and we used very slow movement. That is, in rotational atherectomy, usually you use peaking movement, just peaking and pull back. But in orbital atherectomy, we should go slow, 1 millimeter per second, very slow progress. And by slow advancement, we can gain more orbital gain than first advancement. And this is the IVAS run after orbital atherectomy system. We are seeing some reverberation here. Reverberation is the actually indirect evidence of thinning out of calcium by orbital atherectomy, and there is some crack in the calcium. So from IVAS we see the narrowest part, it was almost 360-degree calcified lesion, and minimum luminal area was 3.4, which is very tight. And orbital atherectomy makes some reverberation and cracks in this lesion. And if we look to this IVAS calcium scoring, for our case, there was 360-degree calcium, there was nodule, and the vessel size was below 3.5, so score was 3. So if it is more than 2, we can use any calcium modification device, and atherectomy is considered. And then we predilate this lesion by 3 into 12 NC balloon at high pressure. So it was well expanded, and we deployed 3.5 and 38 days at 16 atmosphere in proximal to mid LED, and post-dilated by 3.5 12 balloon in 26 atmosphere. Then we put another stent from late main to proximal LED, 4 into 15 days at 18 atmosphere, and we recross this circ and post-dilated by 4 into 12 balloon. This is the final IVAS run. So final IVAS showing there was no geographical mesh, no distal dissection. There is very well expanded stent, circular expansion. Though in ostial LED there was some elliptical expansion, but the MS was very good. It is 8.2, which is wide accepted for a severely calcified lesion. And this is the final CAG look into orthogonal views. And this is a scientific evidence supporting orbital atherectomy. So in Orbit 2 clinical study, it showed this procedural success rate was very high. It's almost 98% success rate to deploy a stent and lesion expansion. So my take-home message to treat heavily calcified vessels represent a challenge for PCI. Assessments of calcification by non-invasive CT angiogram, fluoroscopy, intravascular imaging is essential for planning and treating calcified lesion. Intracoronary imaging, an important adjunctive tool in calcified lesion interventions. It facilitates device selection, identifications of stent landing zones, and optimization of standing results. Orbital atherectomy system has been shown to be safe and effective for management of calcified coronary lesion. And OS has been a specificity of allowing bidirectional atherectomy, which makes it unique, and there is very low rate of bar entrapment because it can cut calcium bidirectionally. So thank you all for patient hearing, and I acknowledge my gratitude to my mentor, Professor Ashok Sheth. Like any other technologies, orbital atherectomy in India is launched on his hand. We did the first case in 4 days, followed by some subsequent cases there.
Thank you, Mahmud, for sharing your expertise with us. We are shortage of time. Now, a few comments from the panelist. From the left side, from the right side. Okay.
I just have one comment. Great case, excellent use of orbital atherectomy. My only question is, it's true that you can utilize orbital retrograde and so actually cut backwards as well. But what was the reason for going backwards in this lesion, in this particular lesion in the LAD?
Yeah. So, go ahead. Iqbal. Okay. So actually for oscillation we can go anti-gate also, but there are some studies they show that for oscillation, if we can cross this lesion, then we can pull it back, and by retrograde fashion, it's actually was by pulsatile force also. In anti-gate way, it better causes differential sanding, and by pull back, it exerts two effect better, is sanding and as well as some pulsatile force.
So I'd answer that by telling you that we are in our early phases of understanding orbital atherectomy for osteal lesions and huge osteal chunks of calcium. So we still do not understand that if we really do it at 120 and give huge orbital, would that be good enough or safe enough as you go through angulated osteas? Though in the center of a vessel, that's fine when it's coaxial. So those are the real issues when you're sitting at the ostia. Your wire may not be coaxial, and yet you're doing a high-speed orbital atherectomy where the burr is actually excessively going around and yet hasn't entered into the vessel.
And are there situations, or what are your criteria for going to the high RPMs, to 120,000 RPMs?
Large vessels, 3.5 millimeters, and nodular calcium.
Okay, thank you, Mahmud.